Welcome everybody to SEVA VentRounds. Today is September 9th, 2025, and today's title is Hiding Trouble or Trouble Hiding. And it'll make sense as we start going through this. It has to do a little bit with ventilator settings. So let's get started. There's no endorsements of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. My conflicts of interest and Rob's are there. The ground rules are simple. Just keep your microphone muted, and whenever you want to talk, unmute it. We're happy to hear your comments. If you don't want to talk and you want to just write it up in the chat, please do so. We have access to the chat too, and we can see what you're putting in, and that's very useful for us. There is CME for those that work at the Cleveland Clinic, and CRCE for all respiratory therapists. Just remember to fill in your evaluation, and we'll go from there. So I thought I made this collage today talking about how ventilators tell us that the patient is triggering. And in classic teachings of mechanical ventilation and in many of the graphs that come in books, they will highlight that we recognize that the patient is triggering by a dip in the pressure waveform. And for all of these waveforms that you have here, pressure is on the top. But you can see up here how there is a drop in the pressure that highlights the presence of respiratory muscle activity, dropping the pressure and triggering the ventilator. And so that's how we have been taught. However, I would, as you see the rest of examples that I have, I want you to look for that, and you will realize that it's not present all the time. In some of them, it's very evident, but as we're controlling the pressure, those may not be present at times. And what we are left with is using markers that the ventilator will tell us that it's triggering, that the patient, it's a signal from the patient that it's triggering. And I find that very useful, at least for me, to recognize the type of patient-ventilator interactions that are occurring. So let's take a little bit more of a look into them. So if you see here, this is a servo U. The first two are servos, and you'll see that it's white on the upper part, and that is pointing that this is triggered by pressure up here. And the color change is now in the next one is on the bottom one on the flow waveform, and that tells you that it's the flow that it's being triggered. So here's telling you it's a pressure trigger, here it's a flow trigger. Doesn't always work perfectly. There's some little nuances, but we don't need to get into that. But that's how the servo shows it. The next three ones are the Hamilton, and I put it here because here they use a little bit different scheme. And the scheme here is they put in a pink triangle when it's just the same color as the flow, telling you that this is a flow trigger. So pink, because it's the color of the flow trigger, is pink. And then if it's pressure trigger, then you see it in yellow. So the color matters here towards what is triggering. And you can certainly see here in example number 2 and 3 that there is essentially no drop on the pressure that you would recognize. So if you did not have this marker, it may be hard for us to know that this is actually the patient. You could infer it, but it's hard. On example number 4, this one with the yellow triangle, which is pressure, you can see a little bit of that divot. And then on example number 5, here on the blue triangle is talking about IntelliSync. So the trigger is done using an algorithm from the machine that decides how to trigger. And I'm not privy to how that IntelliSync triggers itself, but it's there. And you can actually see a blue line happening afterwards, and that means that is there is also the cycle threshold
is also automatic. And so now they're giving you two information here for how it's set. And this is the IntelliSync for trigger and for cycle. So I put both there for you to recognize. The sixth example, this one over here, is the CareScape GE ventilator, and you can see a change in color, again, signaling, and it doesn't tell you if it's pressure or flow. I presume that this is pressure just because of the amount of activity that you have to do, but I cannot tell by the color. The next example up here is another ventilator that is coming out of the market, but still pretty available all around the world, is the Puritan Bennett. And in this one, it will put an S for spontaneous or an A for assisted. And so both, one refers to the mandatory breaths, S for the spontaneous breaths, but it means that it's triggered by the ventilator, by the patient. And that's how it shows. So this one is a little bit tricky because your eyes have to be looking at the corner with each one of the breaths to see if you catch it, and it tells you who triggered the breath. Down here, it's another ventilator, and yeah, this is the Bella Vista, and the Bella Vista does something more tricky. So when it's a mandatory breath, it leaves it hollow, and when it's patient triggered, it shadows it. So spontaneous, it shadows it. So you see so it's a mandatory, spontaneous, mandatory, spontaneous. And then here on the two white screens, or it's these two examples over here, those are Dragers. And the Dragers have different presentations. In one, they put this little set of lungs with a diaphragm underneath to tell you that it's a patient trigger signal. Or in other versions, it changes the color of the flow signal to tell you that it has been triggered by the patient. So all of these to highlight that there's not a universal way that you get to see how the ventilator is triggering. And two, to highlight that sometimes, even though the patient is triggering, the ventilator is triggering, that the patient is triggering, sometimes even when the patient is triggering, it's a signal from the patient that the ventilator is interpreting. You will not see a change, just like over here. I don't see any change on the pressure or the flow that would tell me that's the patient. And the same over here, it's very hard for me to see. So it has turned that now, with the level of technology that we have and with the screens, the usual dictum of that you would see a pressure dip in your pressure waveform is no longer true, and you have to rely on the ventilator telling you if it's a patient signal or not. Rob?
And that just goes to show that some of these schemes are easier to read than others. I wonder on the Hamilton scheme if that's a challenge for colorblind people. And also to point out that the terms assisted and triggered are conflated by manufacturers frequently.
Yeah, great points, Rob. Without a doubt, there's ventilators that, I mean, in part we're used to dealing with them, but you have to really know your ventilator and read down and sit with it and play to see sometimes where the marker is going to come and how does it come. And I did find sometimes in certain ventilators that I was looking at screenshots and it was evident that this was a patient triggered breath, but with no markers. And so then I was completely off, although that ventilator should have shown it. So, and I really do appreciate your comment about color blindness, because that's a major issue. We should not leave. So the two next images come from the Instituto Nacional de Enfermedades Respiratorias in Mexico. This is the National Institute of Respiratory Diseases. And we had a class last week with the residents in pulmonary critical care, and it was just a treat. And they sent me a bunch of images. So I chose two of them that I thought had something that tells me that it's either we were hiding the trouble or the trouble was hidden. And so let's start with it.
as always, the first item is the tag. So if you want to write the tag on the chat, that we would welcome that. So this is a Hamilton ventilator. You can see the mode on the top. You can use your and they start seeing aerosol coming up with some interaction. So I will wait a couple of seconds to see if anybody else. All right. So Arsal is the lonely tagger today. Good job, Arsal. So he said this is PCCMBS, which means that the pressure is controlled, and we certainly see that the pressure is controlled throughout the breaths, and it stays at the same height. It doesn't change up or down. All breaths are mandatory, and we know that they're mandatory because we look for the little triangle, and we can immediately see that there are several of those breaths that are triggered not by the patient, but by the ventilator. So the absence of a triangle says that it's machine triggered, which makes it immediately a mandatory breath. We also see that all the I times are the same length, and that tells us that it's cycling by time, which just immediately make it, again, a mandatory breath. And I don't see any change on pressures or any other feature that would tell me that there's other targeting. So this is set point, meaning that you set up everything, the pressure, the time, and whatnot. Rob?
No comments.
All righty. So the next question that I have for the team is, what is the load? Is it elastic, resistive, or PMOS during inspiration and expiration? Inspiration and expiration.
A lot of PMOS, both.
Yeah. So as we take a look at the waveform, there's not, and let's start with the inspiration, and the inspiration is not, I'm going to avoid this breath over here. So we're going to ignore this one. I know that it looks like a double trigger, but I want you to ignore it because that's an extra a breath that the screen is refreshing. And I know that it's refreshing because you see how it's cut here and here. So forget about this breath that I'm crossing out here, because that's just noise, and I don't want you to get confused. So there's one breath here, second, third, fourth, and fifth breath. Okay, and there's a little bit of a sixth that it's happening back here and that it continues up here, but we'll stick with these five, the six right now. And if we look at the flow, remember, because we're going to controlling pressure, we look at the flow. If you look at the difference between 1, 2, 3, 4, and 5, there's none of them looks the same, right? So the reasons why they would not look the same between them is that something has to be changing. So either your compliance or resistance is changing during the breath in each one of them, which is less likely, or there's PMOS, or there's something that could be PMOS, meaning there's a lot of noise that is getting in between. And that could be it, that it's actually generating oscillations. You also notice that the flow is not the same height. So for all these, the last four is the same height, but this one, the flow is a little bit lower. And you see here this bumpity dump. Here there seems to be an exponential decay. Here's a little bit of a bump, another bump. Here it falls, and then there's the bump. So I would say that this is PMOS or something else until proven otherwise. So that's how I would put it. And Rob, any comments?
No, that's pretty confusing, but that's, I guess, until further evidence, you'd have to say something like PMOS because it's a fairly big change in the flow.
It's a marked event. And if we look at the expiratory flow, you can see that it returns to baseline really fast, right? So this would be consistent with what? Elastic, resistive, or PMOS. Yeah, so that's consistent, correct, with elastic. It's rapidly, and if the patient was doing an expiratory effort, it should be moving away from it. But again, you see those, you probably see a little bit of a divot here, not very marked, a little bit one there, maybe there. This one is a little bit here. So certainly there's some noise there, but I would say that this is mainly elastic. And I would say that during inspiration, even though there's PMOS, this is consistent with an elastic load regardless. So I would say that this is an elastic patient with a lot of noise in between. There's stuff there in and out, right? And so we come to the patient ventilator discordance. I will highlight that there's two breaths that have been triggered by a patient according to this. You can see one right here, right? And there's another one right here. So breath number 6 that continues over here, and breath number 1, both of them were triggered by the patient according to the ventilator. According to the ventilator, and it was using a pressure trigger rather than a flow trigger. And we know that because of the color is yellow or whitish or off-white, egg white, whatever is in trend these days. And so there's two breaths that are patient triggered. And actually, for the luck of you, we can actually see the little divot. You see that? And on breath number 1, there's some sort of divot, but there seems to be a divot. In breath number 2 and 3, you could argue that there's a divot. On 4, there's none. But these are marked and the ventilator picked up on them, correct? So as we think about this, I'm going to pause and ask you, well, how do you think the trigger is for this patient? There's two breaths that are triggered, and then you see a lot of noise everywhere. I mean, this is noise galore throughout. So is there normal, early, late, false, or failed trigger? I start seeing some input starting to come in. Yeah, well, we all would, Ariel. So the issue here is that you have a couple of breaths that have been placed that says that it's the patient. So these two triggers, the patient seem to have triggered the breath according to the ventilator. And then let's analyze the rest. So you come through, and this is these are mandatory breaths. And if you notice, breath number, I would say that from around, oh, I have to change the color, sorry. I have only an eraser, so pen. So from around this spot here to this spot over here, these breaths are identical. Look at the flow. So the patient exhales, about the same peak expiratory flow, not much change. And then there's these two oscillations that cross the baseline, two oscillations that cross the baseline, two oscillations that cross the baseline, two oscillations that cross the baseline. You see that? Very regular behavior here. And so, and it crosses the baseline with a significant amount of flow. I mean, this is above, and if I move over here, it's probably close to, I don't know, 10 of pressure. And actually, remember that the flow, it gets amplified, and you can see it better over here. And you can see how the volume has this notch here, which we recognize here. And then there's inspiratory flow right here. So this is inspiratory flow, inspiratory flow. Here it's even more marked. Inspiratory flow, inspiratory flow, inspiratory flow, inspiratory flow. So it looks like during these periods outside, there's oscillations that are causing a little bit of air, more air to come into the patient. And so that's, again, can be two things. One, it's a patient that is breathing very fast, but very little, or because they're so regular, they are cardiac oscillations. That's the only other two etiologies that can cause this. And Mauro voices, well, this is the capnography also is consistent with ineffective or false trigger. And absolutely, I mean, this could look as a false trigger. So the differential here is either that there is a failed trigger, meaning if this is PMOS, then this patient is trying to trigger here, and the ventilator setting is too high that it's not letting the patient. So we change it to pressure triggers to hide failed triggers on a patient that it's very weak and is breathing very, very little. Or these are just cardiac oscillations because it's not triggering breaths. Perhaps these two are failed triggers. These could be failed triggers, breath number, or false triggers, sorry. Breath number 1 and breath number 6 could be false triggers. Rob?
I'm just trying to puzzle this out like you. This is a Hamilton ventilator, which has a flow sensor at the airway opening.
Yeah.
So the flow sensor is seeing flow in the inspiratory direction.
Yep.
So that's either something sucking in the chest or an intermittent leak, like around the cuff or something like that. Or even maybe out of a chest tube.
Yeah, what I would expect then there to be a major difference on tidal volume, but and perhaps instead of an elastic load to be a high no to see the end. So I think that this is one of those interactions that needs a maneuver. And without a maneuver, it's hard to define what's going on with the patient. Obviously, there's two maneuvers, I would say. The first one is to put the hand on the belly of the patient and look at the patient and look at the neck and see if there's accessory muscles. If this is over assistance and these are failed triggers, you should see some evidence of the respiratory muscle activation. If this is a false trigger, you should see none. And if this is cardiac oscillation, sometimes you get to palpate the heart and you can march it with what you're seeing there. But absent that, the next thing to do is to do an end expiratory pause. And then when you do the end expiratory pause, if this is, this will allow you to see if there's PMOS, marked PMOS, and then if there is rhythmicity to this and the patient is moving and generating pressure or not. So that's the next step that I would do. But this would be very suspicious that somebody changed to pressure trigger to control either the cardiac oscillations causing failed trigger, or, sorry, cardiac oscillations causing false trigger, or failed triggers as a manifestation of over assistance. Because this patient has very high elastic load. And so both can be present on this patient. So that would be my read, Rob.
Yeah, that's a good hypothesis.
Yeah, so that's how, and that's where I would stand. I want to see if there's any other comments. I appreciate especially the comments on the capnography. The capnography is a good thing to use in this setting because you can see usually when it's cardiac oscillations, you will be able to see actually it will go up and then it will start doing something like this rather than go all the way down as if it's a full exhalation, which is what we see here. Yet the elastic load is so high that it may be that's the reason why you see that. I agree with Ariel. You can also put a pulse ox that goes connected to the Hamilton. It has a port for a pulse oximetry, and then you can march and measure with your cursor the cardiac oscillations with the ones that you have on your screen. So both are good, great tricks. All righty. So that's one case. And now I'm going to show another case. Unless I don't see any other comments. Rob, any other comments on this one?
Nope, that's all.
So just to finalize this, the suspicion here is that there is either a false trigger from cardiac oscillations or failed triggers at a very high rate from over assistance in a patient that is very weak. And the way to diagnose this is to do an end expiratory pause to define this, or using other technology like the plethysmograph to see the pulse on the screen. All right, this is another one from the National Institutes of Respiratory Diseases, and I appreciate it because it was cool. So for this one, we do not have the tag, but I'm going to challenge you to try to give me what do you think is the tag for this mode. And I'm being unfair, I know, but it's okay. I will take the anger management. This is how they gave it to me, but there is enough information on the screen for you to answer this. There we go. So rapidly, the team is getting on it, and it's saying BCC MBS. And I will ask Arcel, since you put it there, why did you think this was volume control? What was the clue that gave it to you?
I think your volume is consistent across all breaths. And then if you look at the flow waveform, it's absolutely constant here. Just when you're controlling flow and volume, it's most likely going to be volume control.
You know, Arcel, that's why you're such a good fellow. High quality. SEVA star for you. So absolutely, all of those are great keys, and I appreciate even more the fact that Arcel was looking at the waveforms and not at the tidal volume, because that would be an easy thing to get erroneous, because then you would say, oh, it's the tidal volume is set, but we know that there's modes that we set the volume under pressure control, so that is not your item. So great. What is the load? Elastic resistive PMOS. Yeah, I agree, Alejandro. I think that there's several features here that makes us suspect that there's an increased resistive load. So during inspiration, I mean, we control the flow, but you can see a steep rise on the pressure as the volume. These are mandatory breaths, so the pressure goes up, and you can see the pressure goes rapidly up, and then it comes down, and this comes down due to what we're going to talk in a second, but this is not a passive waveform. There is evidence of PMOS through the breath, not through, but in the later part of the breath. But if this had continued, I would suspect that that was one of the features. And the next one is that if you look at the expiratory phase, the expiratory phase, I mean, doesn't look pretty at all. I mean, there is not even a peak flow, which is a bad, it's a feature of issues. And then there is no exponential decay. And if anything, may be consistent with expiratory effort or increased resistance. So whenever we see this, the active thing is either activation of the expiratory muscles or there is increased resistance on this patient. Rob?
Almost looks like flow limitation, doesn't it?
Yes, it does. It looks like what you would expect on an expiratory limb of a patient with a tracheostomy, right? No peak flow and a constant flow consistently because of severe flow limitation. And then you have the PV discordance. So what do we think about the trigger? There you go. Right at it. Demonstrating fellow power. Megan, Alicia, Arsal, Alejandro, great job. So these are all, and this is why it's so relevant to have a marker that tells you that it's a patient or a mandatory breath, because you need it to help you understand what's going on with this patient. And so here, all of these breaths, there's none of them with a marker of a patient-initiated breath. So these are all mandatory breaths. And because we're controlling flow, we look up the pressure, and you can see that after the pressure goes up and the flow is constant, there is this major dip on pressure that starts here and ends all the way over here. So I'm going to say that this is all PMOS. But just for the sake of it, I'm going to draw out how these waveforms should look, because that will help you put it in your brain how, in a constant flow, how should this waveform look for us. And so when the initial step up on pressure, you would expect the pressure to go up, and then it would be a straight line because the flow is continuous, and there would be a point at the end of the breath where it would come down, something like that. I'm a little bit off, but so we're missing all this peak over here, all this area that I'm shading, and that's why it's so important for you to memorize how the waveform should look in a passive patient. So you have lost all of that peak, and the only way that you can lose that peak is by PMOS. And then the breath ends and starts expiration, and in expiration you control flow. You control pressure. So my eyes now go down here to look at this, and you can see that the flow has crossed the baseline, not a little bit. I mean, this is a major crossing, right? And crosses off, and then finishes the PMOS, and then it relaxes or goes into exhalation. So this patient is having, without a doubt, an early trigger. So it's mandatory, followed by evidence of patient effort that starts more or less here and ends over here. And so this is an early trigger. And when I see this graph, the first thing that came to my mind is somebody decided to hide the problem, because this patient probably was double triggering breath after breath. Every single one of these should have been in a good setting, another volume control breath right here. It should have come and deliver another breath, to which the patient would have gotten 950 cc's of tidal volume, which I can imagine that was not something welcomed by the team. And so seeing this large double breath, they said this is not a good thing. And so they went and changed the flow or the pressure trigger to a pressure trigger that would not allow you to trigger the next breath, essentially locking out the patient from getting the second breath. And it's getting some flow, no doubt, and some support, you may say, from because it's on PEEP, has some PEEP there. But essentially, the patient took a breath and then continued to take a breath afterwards, and we canceled the ability to double trigger by changing the threshold. Rob?
Megan says the trigger threshold must be high. That's just what she said.
That's
sensitivity
correct.
is low, is threshold high.
Yes.
Also,
exactly.
that little hump in flow must be the patient sucking the gas out of the circuit, right?
Well,
the circuit is collapsing.
because
Otherwise, they would have triggered, right?
Well, that's it all depends, Rob, I would say, because you're on the expiratory phase, right? So
Yeah.
so the ventilator is controlling pressure. So if it sees the pressure go down, it should give flow to maintain the pressure at that given, unless
Yeah.
your trigger unless your trigger is a pressure trigger, which we have seen that they kind of limit. I don't know how they do it, and you perhaps can answer this a little bit better. But the fact that it doesn't drop it as much makes me suspect that they left a flow trigger with a very high threshold.
Yeah, that's
for it.
probably a better explanation, right?
Yeah, this is very, very, very interesting. So that's why, again, we are hiding trouble by changing the sensitivity, and that's what I suspect that it's occurring on this. But again, a beautiful case of early trigger. In general terms, the way that we deal with this, especially with a patient with such a high resistance, would be how? How would the team deal with this reverse trigger? Yeah, Megan. So what would you do? How would you? Yes, drop the respiratory rate. Great job, Arcel. So these are patients in which we would drop the respiratory rate as much as possible, so that this patient is coming out of sedation or it's on sedation, and these are the manifestations of sedation, and let them start driving the rate themselves. And so that may be the next step. Now, sometimes you cannot control this. The risk is too high. Maybe this patient has severe obstruction of the trachea or something along those lines, and the team is very concerned. And I mean, then sedation is the answer, right? So yes, depending on the goal, absolutely. But in general terms, I would say that if I see this, my first reaction, even if my goal is safety, if I have the ability to, I drop the rate. That's my usual first behavior. The level of evidence for this is mainly expert opinion and anecdotal, and based on what we know about this process. But that's how we do it. Very good. All righty. So the key findings for today are I think that we reviewed the importance of recognizing the patient triggered markers. And these are very varied and different between ventilators. Varied and different between ventilators, and you need to review each one of them to try to figure out. We also talked about the importance of end expiratory holds to help you recognize the cause for certain discordances. In particular, false trigger and faith trigger, this can help you. And I think that these are pretty good take-home messages in general terms for all of you. Rob, any other?
I would just say that in general, decreasing the trigger sensitivity is not the answer unless you have a false trigger because of an extraneous signal. But if you try to lock out the patient, that generally doesn't end up in a good place.
Yeah, that's absolutely right. And sometimes these patients have such a high cardiac oscillation that trying to find the appropriate trigger is very hard to do so.
Yeah.
And so there's some tricks that we can talk a little bit more in another version of SEVA VentRounds on how we deal with these patients which is very hard. Yeah, good job, Ariel. Yes, you always want to check and examine your patient to be sure who and how is triggering. Again, here's the CME for our CCF caregivers, the CRC for our RTs. Send us your waveforms. As you see, we'll highlight your team, highlight yourself. If we get your waveforms, it helps us grow and learn. There is no boring waveform. I'm still waiting for one in which I don't have anything that I can say. Perhaps even if it's a blank screen. The SEVA Summit is going to happen tomorrow. It starts tomorrow, and we're very excited about that. So if you want to be part of the SEVA Summit, register. The dates are out there, April and September every year. So you can register right here. So thank you very much. I hope you enjoyed this. I did. And I know that Rob, just based on your facial expression, did too. And so have a great day. Great job, fellows, for everything that you do.